It's Associate Professor Henry Wu, who regularly speaks to us, is always entertaining, always informative, always relaxed and happy, as you can see, and of course is always very, very pleased to have your questions. Please welcome Associate Professor Henry Wu. Thank you.
Yeah, thank you very much. Can you hear me? Great. Thanks very much for that introduction, Graham. It's actually been a little while since I last addressed this audience, and for various reasons, personal and also other work-related issues, it's been a little while. But I was absolutely determined that I wanted to speak to this group again at some stage. And I was just telling Graham just before how coming down here and talking to you guys is like talking amongst a group of friends. So it's quite a relaxed sort of environment, and as I said, it's amongst friends, which is great. All right, I'm going to talk to you about hopefully a topic that hasn't really been covered to any great extent in your various meetings. Typically when a urologist comes to speak to you, they'll generally talk to you about surgery and what it does, and and a lot of, let's be honest, for a lot of you, you're already way beyond that. And whereas some of the content, a lot of the content for today, I think will be, or tonight I should say, will possibly be relevant for a number of you, and certainly will be very relevant for men who are already well into their journey of treatment for prostate cancer. Right, firstly, just my disclosures. I don't receive any speaker fees or travel grants or honoraria from any drug company or medical device company. It means I do everything for free. Yeah. All right, firstly, I'm going to just talk a little bit about this concept of high-risk prostate cancer. I think you're generally familiar how when somebody is diagnosed with, say, localized, or in other words, non-metastatic prostate cancer, we tend to divide it up into three categories, which is low risk, intermediate risk, and high risk. And in the past, high-risk disease was often not treated at all. We simply say, oh, if you've got high-risk disease, you're going to be in trouble, it's not worth treating. And we were very keen to operate on the low-risk cancers because we honestly believed at that time that we were going to make a difference. Well, the first, description of what high-risk cancer was one put together by a fellow called Anthony D'Amico from Harvard. And it's defined as being a localized prostate cancer that has one or more of any of these criteria, which is having a PSA greater than 20 nanograms per mil, having a clinical stage T2C. Now, what do I mean by T2C? Well, that means when a urologist puts the finger in the rear end and the prostate feels feels cancerous on both sides of the gland. And the third criteria was if the Gleason score was 8 or more. And you're probably familiar with the Gleason scoring system. And just very briefly what it is, it's a scoring system that the pathologists use to try to give us some sort of idea as to how aggressive or what the biological potential of that cancer is. It's an interesting system where the lowest score is actually 6 out of 10. And everybody's going, well, what do you mean 6? What about 1 to 5? Well, I think the simplest way of putting it is that this system was devised in the 60s, and if it was today, I think we would have done a bit better. It's very difficult to change an old system. It's going to be like trying to get the Americans to switch over to metric, and sometimes you've got to accept it probably ain't going to happen. But anyway, they're the criteria that define high-risk prostate cancer. Well, we've got those criteria, but still, what does high-risk prostate cancer mean? It basically means that if you have these criteria, you're more likely than the average punter to end up with recurrent cancer in the future. It also means that you're more likely to have hidden microscopic metastases. In other words, even though all the scans may have shown there's no spread, we've got to remember sometimes when cancers, you get the very microscopic spread of cancer, it's going to be beyond the resolution of any of those scans to detect. So therefore, when men are diagnosed with high-risk prostate cancer, they have to be counselled about the possibility of there being microscopic disease that could rear its ugly head in the future. Since D'Amico came up with his classifications, we decided as a profession to make things as confusing as possible for ourselves. So what we now see are there are numerous different definitions for what we mean by high-risk prostate cancer. So it's critically important that when professionals in the field are talking to each other, we've got to make sure, are we talking about the same high-risk prostate cancer? Now, some of the consequences of high-risk prostate cancer, well, we've now realised that with high-risk disease, it can be associated with local disease problems if we don't treat it. So what do I mean by local disease problems? Well, and not treating it? Well, if you have a high-risk prostate cancer and you don't treat it with radiation treatment or with surgery, these cancers are much more likely over time to cause problems with blockages and bleeding and possibly pain as well, just from the actual cancer in the prostate. So that's become increasingly understood. And as I mentioned before, it has a very significant association with existing microscopic spread, even though you can't see it on the scans. And how does that manifest itself later? Well, eventually over time, those microscopic spots will become visible on the bone scan or a CT scan, and with that, you'll often see the PSA starting to rise. Excuse me. The other thing which is becoming very interesting in these so-called micrometastases is that the way in which we define non-metastatic prostate cancer could well change, and it probably is going to change very significantly very soon. And I'm going to talk a little bit more about that later on. And the reason is because there are a number of new scans that are just starting to become available. For example, with the PET choline scans, which I'll talk about a little bit later, that's only been available for maybe a couple of months in one location in Sydney, but very soon others will probably be offering it. And within months, that PET choline is going to be superseded. That's how quick it's happening. It's going to be superseded by another scan called the PSMA scan. And just around the corner, we're aware of other very fancy types of scans which will probably supersede the PSMA scan. So it's unbelievable what is happening in the field in imaging. Just when you thought that, well, we've done the best we can, we actually are doing much better. All right, look, in principle, some of the real problems we've had with prostate cancer over a number of years is that we have over-treated clinically insignificant prostate cancer. But at the same time, we're actually starting to realise that we've also been under-treating clinically significant prostate cancer. So in other words, the really aggressive ones that we shouldn't have been sending off to just have watchful waiting and then have hormone treatment, they're probably the ones we should have been treating more aggressively in the past. Now here's an example. What happens if somebody's got a high-risk prostate cancer and we manage them by watchful waiting? Or in other words, they eventually go on to androgen deprivation therapy, also known as hormone therapy, and go on that treatment alone. So that means patients who do not have surgery or radiation treatment to their prostate, and we just wait and see what happens to them. Well, I'm getting like the rest of you. There's no way I can read what's on there, so I'm going to make life easier for you because these are some important studies. Now I can read it. And the thing is that these are the outcomes when men are treated with androgen deprivation therapy alone. The main one to look at is, in particular, if you look at the 10-year overall, the 10-year disease-specific survival, 76%, 10-year overall survival, about 60%. So these are non-metastatic as far as we can gather at the time of diagnosis. Obviously, the figures are much worse if you've got visible metastases. But when you compare that to patients who had radiation treatment, you can see that there are some significant differences here. These two here are from different studies, and these three here are from the same study. But the key thing is that when you look at PSA recurrence in particular, for those who've had radiation treatment, it's substantially better than ADT alone. The reason I showed you those figures, because those figures are from what we call randomised controlled trials. Because one of the problems we've got is when you just pick out a group of men who've had hormone treatment, and when you try to compare them to men who've had radiation or surgery, often there's different selection criteria. So in that data I've just shown you, they are actually selected with the same criteria as to whether they had radiation treatment or whether they had watchful waiting and hormone treatment. All right, I talked about, if we had more sensitive scans, we probably would see more metastases than we are just with the conventional bone scan. Incidentally, the bone scan that we have now, it's been around for decades. It's amazing that we've got something where there had been no real advance for so long, and we've been using this outdated technology. And many of us are calling for us to stop using bone scans and start using some of the more modern forms of imaging. So what would happen if we were to treat men who actually had visible spread? What would happen? In fact, that's something we would never contemplate doing in the past. Imagine giving radiation treatment or prostate or surgery to a man who's actually got metastatic disease deposit you can actually see. We would normally say that they've gone too far, don't bother. But the interesting thing is that over the last 10 years, surgeons in other specialties have been doing just that. And they're discovering that men are actually having a substantial survival advantage if they were to have the primary cancer removed. Well, this very provocative paper was published late last year, so this is really quite cutting-edge stuff. And I think this is the version that was published online ahead of print towards the end of last year, and I think it's only just hit the print in the last month or so. So you can see this is really cutting edge. And the paper here says, might men diagnosed with metastatic prostate cancer benefit from definitive treatment of the primary tumour? A SEER-based study. Well, the SEER is actually is the Surveillance, Epidemiology and End Results database or registry kept in the US. There's a huge number of institutions who are submitting their data to that. Now, the thing is that what's very interesting is that the investigators looked through that, and I was absolutely flabbergasted that there were so many men being treated with metastatic prostate cancer. So there were people doing it outside clinical trials, and the reasons why they were treated is a little unclear, but the fact is there were a lot of men actually being treated. It's one of those things that urologists in the US weren't admitting to. But, and that's the interesting thing about these retrospective databases. You go back and you actually find, people have been doing this. So anyway, they looked at a group of men who were treated between 2004 2010, and they're only able to draw out the men who were treated either with a radical prostatectomy or brachytherapy. The problem with looking at external beam radiation treatment, they couldn't look at it because the way the coding worked was that they couldn't tell if the radiation was to the prostate or to some other part of the body. There just wasn't enough information on the coding. And this is now these sorts of survival curves are actually quite complicated, but I'll try my best to simplify it. This side here is your probability of being alive, and on this side here, and imagine that one is 100%, okay? And on this axis here is the time from initial diagnosis, getting out to 80 months there. Now this blue curve here is the curve for men who had neither surgery or brachytherapy treatment. And this green curve here is for those who had brachytherapy, and the red curve here is for those who had a radical prostatectomy. I think that you don't have to be a science expert to see that these results are almost mind-blowing, that there is such a difference. Now, it's very exciting, this sort of thing, but we have to contain our excitement because we need to do some properly conducted trials. Because the one thing we don't know is sometimes we don't fully know the thought process that went into selecting the men for each of these treatments. And it's possible that maybe those who had no surgery or radiation treatment would have men had the Christmas tree type bone scan, whereas maybe the men who had the radical prostatectomy and the brachytherapy only had, say, 3 or 4 metastatic deposits. So it may not be apples, can bring apples with apples, and maybe apples with watermelons, for all we know. But you can see that it does present some very interesting, it's very provocative, and it certainly makes us think very carefully about something we should be considering doing. And this is sort of showing the graph in another format, showing the cumulative death. And the bottom line is that if you had no surgery or brachytherapy, you're almost twice as likely to have succumbed to prostate cancer, say by 60 to 80 months. All right, I want to talk a little bit about the concept of oligometastatic prostate cancer, and this is another really hot topic, which is in the same theme about getting really aggressive about treating aggressive prostate cancer. Now, it refers to low-volume metastases that are clinically evident, or in other words, ones you can actually see on your scans. Again, we've got a little bit of a dog's breakfast on definitions again, because some centres will say that we define oligometastatic disease as being 3 spots of spread, and another centre will say, it's 5 spots of spread, or they've got to be less than a certain size. So that's something that we need to sort out, but it's a very new concept. And the other thing which also influences the definitions is what type of imaging you use. For example, if you use one of these super fancy brand new ones which aren't even available on the market, like it's called MRI Combatex, for example, is an example of a scan which is not yet available, but allegedly can read down to 2 millimetre size metastases. Imagine you had that, then that could alter your definition significantly. Now, it all sort of started it's only just started in the last 7 or so years, 5-7 years, where it started with just a couple of case reports where some doctors, for whatever reason, decided they would treat very, specific men. Maybe it's because they were particularly young men where they wanted to throw the kitchen sink at them. For example, in 2007, this author just wrote up a case report where they took out a solitary lung metastasis from a patient with recurrent cancer, and they reported their results 3 years after the lung lesion was removed, and the man had an undetectable PSA. Now, under normal circumstances, you think that once it got spread, that's it, forget about them. And then Alongi presented a case where a man had previously undergone a radical prostatectomy, and they used this thing called it looks like exclamation marks instead of ones. But anyway, they're meant to be. It's 11 carbon sort of choline, a choline PET scan, and they picked up one lymph node and they treated this man with aggressively with radiation treatment plus chemotherapy. And 2 years later, without hormone treatment, his PSA is undetectable. So it's starting to get people thinking. Well, this is a study, again, I don't expect you to be able to read it, but it's more just to illustrate the point that the radiation oncologists were actually onto this before we were. And they actually started using Salvage Stereotactic radiation. So it's a very fancy way of just honing in on a lymph node that you can find. So therefore, men who had previously undergone either radical prostatectomy or radiation treatment were then being imaged when they had PSAs going up. And when they found these lymph nodes, they gave them radiation treatment. And the amazing thing is that you're getting as many as up to half of the patients having PSA biochemical remission at a number of years down the track. So we're starting to see some numbers instead of just a couple of case reports. Now, this paper here is published online ahead of print about 4 weeks ago. So again, this is really cutting edge. And now this, instead of radiation treatment, what they've done is they've actually used surgery. So they picked up, so you had the scene is where you've got these men who they've undergone a radical prostatectomy in the past, and the PSA is starting to rise. And normally we assign these men, we say, oh, okay, look, try radiation. It doesn't work because there's probably micrometastatic disease. And what they did was they put these men through a choline PET scan, and it picked up visible lymph nodes. And imagine this, they then went in there and operated on these men and removed those lymph glands which was suspected to be positive. And on average, in the lymph node packages, they found at least 3 lymph nodes that had cancer in them, each of the men who were operated upon. And you've got 46% of them had no further treatment after that. In other words, at 3 years down the track, imagine this, you've got these men who normally would have been on hormone treatment by now, were not on it. And the 3-year cancer-specific survival is not surprising. I don't think I'd take too much notice of that because 3 years is too early. No, actually, to be fair, but when you've got men who have got signs of spread, well, you expect there actually to be a greater cancer-specific mortality. So they actually are quite good figures because these are men who have got advanced cancer. And this study here, again, I don't think it's critical for you to see the detail of that. But the key point is that we tend to focus a lot upon, you know, how many men are going to be alive, but a very important thing to also consider is the quality of life associated with delaying androgen deprivation therapy. So if you're a fellow who's been told that if we managed to find a lymph gland somewhere and we were to say give it radiation or surgery, and whilst we know we won't cure you, but if that was going to delay you needing to start hormone therapy for another 3 years or 5 years, I think a lot of you would say, yes, please. And I know some of you are in that situation where you went on to hormone treatment, but isn't this amazing just how things are changing? It's phenomenal. There needs to be a lot of studies to help confirm these findings. You know, we have to be very careful about containing our excitement and not just rushing in and operating on every man's lymph nodes, you know, or salvage lymph node dissection, trying to fish out all the cancer we can find. A lot of these new imaging modalities still need to be tweaked a little bit more. One of the problems we do see is where sometimes the technology becomes available way ahead of the actual evidence to show where to best position it. It's interesting, as I said before, I've mentioned that I do want to talk about some of the imaging, and this is where I want to talk about it. The new sort of imaging that's now available is called a PET choline scan. There are 2 types of PET choline CT scans. A lot of the ones used in the literature where it was labelled to 11 carbon was the main atom the choline was attached to, whereas mostly now, that was developed by the Mayo Clinic, and so a lot of the older studies use that, but it's much more reliable using attaching to a fluoride, so it's an 18F fluorocholine scan is what most places are now offering. Now, everything has a cost to it, doesn't it? That's the trouble with new technology. But the cost of a PET choline scan in Australia at the moment is roughly around about $900. Now, it's a lot of money, but the thing is that the way I look at it is that if a man's getting to a stage where they need to have a PET choline scan done, well, we put away things for a rainy day. I think this is the rainy day. And compared to the cost in the United States, a PET choline scan there costs around about $3,000. It's absolutely insane. Even an MRI in the US costs around about $2,000 or $3,000. So, you know, we're kind of lucky that we've been able to contain that cost quite reasonably here. The hot on its heels is that other scan called the PSMA scan. That's that's another marker which is proving to be quite exciting and much more sensitive and specific than the PET choline scan. And my understanding is that I think that there'll be 2 places offering that in the next 4 to 6 weeks, as early as that. And that'll be over at the Royal North Shore Hospital and at St Vincent's Clinic. And we're currently, I promise you, we're currently working on trying to make sure the SAN is getting one of those scanners as well. And as I understand at the moment, the cost of those scans will be actually less than a PET choline. So imagine you'll get even a fancier scan than the PET choline will be hopefully cheaper. The other sort of imaging that's going to also become much more commonplace, I think, will be MRI in one of its various forms. And rather than, it's my belief that in the next few years, we won't be doing conventional CT scans of the abdomen and pelvis, nor will we be doing conventional nuclear medicine bone scans. And this is how things are changing so quickly. So anyway, this is, the idea of this chat today was to try to talk about something a little bit different, and also to tell you a little bit about what's happening, how the cutting edge is so close to us, and also to give people hope. Because I think these exciting advances really do give people hope. And I think I was telling Graham in the beginning here, there's never been a more exciting time to be a clinician and researcher in the area of prostate cancer. Really exciting. I'm very happy to take questions on anything related to this presentation or prostate cancer in general.
Henry, could you just explain briefly about lymph nodes and the role they play in this and what they are? Thanks.
That's an excellent question, and I've I really should have explained that, because I can't always, you can't be too presumptive. People understand what the lymph system is. Okay, we'll go back to basics. As you know, we have a circulation where we've got an arterial system which pumps all the blood out to our tissues, and we've got our veins that return the blood back to the heart, and or back to the heart and lungs to be reoxygenated and pushed through again. Oh, sure. Oh, okay. You want to see that? Really? But the thing which a big secret is that the amount of blood, the amount of fluid that goes back in your veins is actually a little bit less than what was pumped out there. So there's a bit of a, there's a sort of missing amount of fluid. And what that fluid is actually the lymph fluid, because the lymph fluid provides another mechanism by which fluid gets back to the heart. So when the arteries push blood into the tissues and oxygenate them and give them nutrients, not all of that stuff makes it back into the capillaries and back into the veins. It gets soaked up by the lymphatic system. Now, this lymphatic system is kind of like another vascular network, or plumbing network, you could say. And it's actually, this network actually has these little ports, not really ports, but it's like they've got these little stations here and there. And these stations are like lymph nodes, or that's a way of putting it. And these lymph nodes can actually process the fluid that comes through it. Not quite like a kidney, but what it does is it filters it and has a good look at it and says, don't like that rubbish, we'll kill it, get rid of it. So it destroys bacteria and destroys cancer cells. And every organ has a lymph node that it drains to, or a series of lymph nodes that it drains to. And as you guessed it, the lymph nodes can be a first port of call for where prostate cancer can spread. So prostate cancer therefore can spread through the bloodstream, so it gets into the veins and circulates around. And it can also enter into the lymphatic vessels, and then when it hits the lymph gland, the processing centre, it can get stuck there. And if it lands there, it might actually say that I'm happy to be here, and then it starts to multiply and becomes a bigger deposit, and it becomes a target for, it was now becoming a target for removal, potentially. I hope that sort of helps explain it.
Henry, I see some advantages with the imaging technology. I also get the impression that in the drug side of treatment, like you've mentioned surgery and radiation, but less on the drug side. I get the impression that most of the effort at the moment is doing combinational variations and so forth to get a better whack into the problems. The question is, does imaging assist the selection of drugs, or are you actually better off having surgery or radiation? If it's
you're way ahead of the game. You're thinking exactly what a lot of researchers are thinking right now. In fact, there is again, this is really very cutting edge stuff where the new imaging is starting to define different groups of men. So men who have got certain types of metastatic load may potentially end up being more suited for actually going into drug treatment, and certain types of drugs rather than other types of drugs. So they may be more suited for one of those immunotherapy type new drugs which are coming out, like ipilimumab, I can't say it properly, which is coming out, which is on the verge of becoming available. Or they may be better suited for having abiraterone or enzalutamide. We're still working. We've got at the moment we've suddenly got this huge drug cabinet, and we're trying to work out. And we know all of these things work quite well. We're trying to work out how to best sequence them, and imaging is also going to play a role in helping us to sort out what goes first. But that's exactly, we are thinking that right now. It's in terms of combination, yes, combination is a future. One of the reasons why there is some difficulty with combination of drugs with surgery is that a lot of the men who have surgery don't want to have anything which is don't want to have hormone type treatment. And at the moment, most of the advances have been in drug treatments that are going to impact upon, I guess the androgen axis.
In the case of where a patient has had radiotherapy that failed, and then have the prostate completely removed, looking at your graphs, would that sort of stop those sort of trends, or would there be any benefits from that happening, or would there be more downside than benefits?
Yes, well, we're going to get we're starting to get smarter about our assessment of men whose PSAs are rising after radiation treatment. There has certainly been an increasing trend to consider men who have failed radiation treatment for possible surgical intervention. We do have to select them out very carefully. The results, the functional outcomes of surgery have been notoriously bad, but the thing is that we've actually gotten better over the last 5 years or 5-10 years. So the surgical outcomes, I think, have improved to the extent where we wouldn't necessarily say never when it comes to surgical treatment after radiation. Whereas in the past, there's no question, we'd say no way. But we are now increasingly and very carefully selecting some men for surgery. But with the imaging modalities, there's been, it's particularly with MRI, it's assisting us with thinking about, more novel approaches, for example, focal treatment. So we may actually just focally treat the area of recurrence in a radiation recurrent cancer. And sometimes these radiation recurrent cancers may actually also have metastatic disease, and we may seriously think about stereotactic radiation to those lymph nodes.
Henry, I was wondering if you could just talk about robotic. I know you're doing a lot of robotic operations now. How is that progressing, and what's the percentage now of patients having robotic as opposed to the normal operation?
Yes, we haven't quite reached the stage of uptake of robotic surgery in Australia as is the case in the United States. I think it's getting up to 11. By now, it's probably well over 90% in the United States. In Australia, it's rising, and it will only be a matter of time before we reach the uptake that we see in the US. It's one of those tidal waves you can't stop. Robotic surgery it's great. I'm doing robotic surgery, But I'll confess that I was taken a little bit sort of kicking and screaming, because I wasn't absolutely convinced that it necessarily provided better outcomes in terms of cancer removal and continence and potency outcomes. Many will swear black and blue that it does make a big difference, but I'm not entirely sure it makes that substantive difference. But the thing where it does make a difference is that I think that the recovery and the pain experienced after surgery, even though it wasn't that bad after open, is definitely better. So when you do look at these men at the time of discharge, they certainly walk out of the hospital, much better than the men who've had open. So with, I guess that the commercial forces actually have essentially dictated that if you're not doing robotic, then you're not going to have a practice in prostate cancer surgery. We went from, for many years, St Vincent's had the only robotic console in Sydney, and then once Macquarie got its machine, it managed to attract quite a number of urologists to visit there, and they also, as you know, Macquarie, they're very good at their marketing. They've got a fantastic business school there, and they could tap into their expertise, and they did very good. I guess I think it was reasonably quite ethical too, marketing, and to the extent that it was drawing patients from everybody else's prostate cancer practice, and so the dominoes fell after Macquarie installed their unit, and before you knew it, we had 8 units in Sydney, sorry, and all of a sudden we actually had more than Melbourne had, which is where it had become the predominant form of surgery for quite a number of years.
Just another one, Henry. With hormone treatment, it would appear that the major marker one operates with is the PSA rising and so forth. Are there a class of patient who would basically fail, if you like, without a PSA rising, but it's just that the adverse side effects of the hormone treatment be the primary cause for actually going on to some other treatment?
Well, it's firstly about the PSA situation. The PSA, once somebody's undergone primary treatment, or any sort of treatment for prostate cancer, the PSA becomes an exquisitely sensitive tool. In fact, no other cancer has a greater tool as we have for monitoring prostate cancer. Now, we recognise that there is a subgroup of men whose cancers are just so aggressive, and the prostate cancer cells are so abnormal that they've lost the ability to produce the PSA substance. So therefore you can get disease progression in spite of the PSA not going up. And we all hear anecdotal stories about this, but I want to emphasise that these are a very tiny percentage of the overall cohort. Now, we are going to be able to better predict who is going to misbehave with the use of biomarkers. Now, there are numerous biomarkers which are becoming available on the market. They're mostly very expensive, and these biomarkers can actually help predict who is more likely to fail later on. But even going beyond that, it's the genetic biomarkers that are going to be particularly interesting. We've still got a long way to go on that. But in Melbourne, a fellow called Ben Tran is about to embark upon some really good work with understanding the genetics of prostate cancer and how it can apply to personalised medicine. In other words, imagine if you could understand the genetic makeup of somebody's, or the genetic profile of somebody's prostate cancer, and you can then predict as to whether they ought to be treated much more aggressively early with certain types of drugs. It'll help identify when to treat, how to treat, and I guess what drug to treat with. It can make a difference in that regard. So we're going to see that. That's what I mean. This is very, very exciting. You know, every question you're asking, you know, it's interesting. All the questions you're asking, like 10 years ago, we said, oh, yeah, that's all part of the sky. Yeah. You know, but every question that's been asked me tonight has been is something that's actually happening right now. It's amazing.
Henry, that's the last question has probably covered some of the things I was going to ask about PSA test, because over time there's been a lot of controversy about the PSA, and
Yep.
I was just wondering what the sort of current view was and whether these new scans will in fact take over from that.
The new scans will play a role, I think, particularly MRI, in helping us to sort out the patients who don't need aggressive investigation and treatment. Biomarkers may play a role, but the main thing inhibiting that is going to be the cost. For example, if you have, you know, most of these modern biomarker tests cost around about $2,000 or $3,000 each test. So you can see how that's going to really inhibit their routine introduction to clinical practice. But we still have the same debate. We've got a situation where you had, remember sort of in the past, you had two ends of the spectrum. You had the surgeons and radiation oncologists who said that, yes, we've got to screen for prostate cancer, we've got to treat it, we're worried about all these men who are dying from prostate cancer each year. And did you know it was more than the number of women who died from breast cancer. Definitely more than the women who die from prostate cancer. But anyway, breast cancer each year. Then you had the handful of people on the other end of the spectrum saying, no screening, no, there's no evidence, you know, you shouldn't do it at all. More men die of prostate cancer than not. Well, the clinicians, we've moved a long way, a really long way. We've actually embraced, particularly in Australia, we've embraced active surveillance. We try very hard not to treat Gleason score 3+3. We now know that we shouldn't do that. We've also gotten much better with our treatment. There's less problems with incontinence, impotence than we used to have. So all the treatments are much less toxic than they used to be. However, those who are anti-testing and treatment of prostate cancer, they haven't budged. They haven't come even close to halfway. We've moved very close to halfway in that whole debate.
So you're saying that the PSA is much more sensitive after the operation?
Absolutely, that's right. PSA is actually a great tool.
It was more of a movement in the...
Well, the problem was that PSA was we were using it badly. We weren't, I guess, how can you put it? We were using it as an excuse to do a biopsy on everybody. And, you know, it's not with all with good intention, but we now recognise that we have to be much more selective in who we actually bother doing a PSA test on, who we bother to do a biopsy on, and who we actually treat. And a crucial advance was understanding and recognising that low-risk cancer shouldn't be treated and should be treated conservatively in the vast majority of cases. Earlier this year, you probably all heard of a fellow called Pat Walsh. Pat Walsh is one of the most famous urologists in the world, and he was the fellow who is the father of nerve-sparing radical prostatectomy. He was the fellow who converted radical prostatectomy from a fairly gruesome, high mortality type operation to a refined, reconstructive type of procedure. He, Pat Walsh was, you know, probably did more radical prostatectomies just about everybody in the world. But this year he came out with an admission where he said that he made a mistake. And he says that I operated on a lot of men who didn't need treatment. But it's not because, and the thing is, it's interesting, he's actually gained a lot of respect from a lot of people because of the fact that he actually understands that where we've come. And he actually led the way for many years as to, with regards to over-treatment. But he's now making this admission that he was wrong and that many of the men he treated shouldn't have been treated. He also makes the admission at the same time, and unfortunately this doesn't make the press at all, he actually says that there were too many men that he didn't treat, that he should have treated. They just got sent away and they could have done better. Oh, the microphones.
Yes, Henry. I've got this. This question is basically in two parts, and they're quite separate and different. One is in relation to testosterone suppression therapy, and there's something that you should use it not for more than 18 months, or is there a sort of a time limit because of complications? And if you could outline the what the parameters might be in relation to that, and added to that, I noticed that in Melbourne, I think they were using this zoledronic acid as a supplement for treatment. Perhaps that's the first part, and the second part, perhaps I'll wait for the answer first.
Okay. Well, with that first part, there's actually multiple parts within that first part. Let's see. In terms of duration of how long you have androgen deprivation therapy or hormone therapy, it depends on the circumstances. Firstly, the 18-month figure is closely linked to treatment with radiation treatment. And 18 months is believed to be, by the majority of radiation oncologists, to be the ideal time in which a man should have the ADT in conjunction with their radiation treatment. There's been lots of controversies whether should it be 6 months or 3 years or 12 months, but 18 is kind of the magic figure that is being used by most radiation oncologists. This is looking at it on a global sense. In terms of the other situation is the duration of treatment in the setting of intermittent androgen deprivation therapy. I'm not sure if a lot of you may have heard about this concept of where you start a man on hormone treatment, then you stop it, and you start it and stop it. And there's been lots of controversy with that because there has been some mounting evidence that men who have intermittent treatment may have a disadvantage in terms of their cancer mortality. They might. On the other hand, there has been some evidence which suggests that men who go on the intermittent might have improved, quality of life by having the intermittent approach. The more recent evidence that I've attached myself to is the fact that intermittent treatment does not deliver the quality of life benefits that we first hoped for and thought would be the case. Because when you think about it, it takes so long for the hormone treatment to wash out of your system. And then when your testosterone starts to rise, your PSA goes up very quickly with that. And before you know it, your true drug holiday, which really isn't the time between the two injections, the true drug holiday is from when the testosterone rises, which is that's when you start feeling better. And then you need to go back on it. And often it only ends up being a few months. That's what happens in reality. Now, with the zoledronic acid, that's a class of drug called a bisphosphonate, and it works in the bones. And it's very similar. It's in the same class of drug as that drug called Fosamax. A lot of you may have heard of Fosamax, which is used to treat, weak bones, or in other words, a condition called osteoporosis. Now, zoledronic acid is also beneficial in trying to, help people men who've got issue with loss of bone strength. And loss of bone strength is one of the side effects of the hormone treatment or androgen deprivation therapy. So therefore, it has a potential to be beneficial there. But the other thing which is also interesting about zoledronic acid is that it's also got some anti-cancer behaviour. So therefore, if somebody's got lots of metastases or lots of bone spread, it can actually be of benefit in helping with the bone pain and also reducing the risk of those men having complications from bone disease with advanced cancer. Things like what we call pathological fractures, when your bones just snap or break because of the cancer weakness or osteoporotic weakness, or developing bone pain or need for surgery, and a whole host of other problems that occur with bones. So that's why zoledronic acid, you'll find that some men will find themselves on that drug because of those benefits. But these days, a lot of men are actually being switched over. Instead of getting zoledronic acid, then actually quite a few men are getting a drug called denosumab. Have you heard of that?
I've just heard of it, yes.
Yeah, denosumab is another drug which is proving itself to be, whilst no head-to-head studies really, but proving this to be just as efficacious or works just as well. And you only need to have an injection, it's a subcutaneous injection which hardly hurts. Right. Well, it's a tiny one. It's not like a Zoladex injection, those big horse-like needles.
Right. Well, thank you very much. That's that part. Now, this other part is...
Oh, that's right. I've got another one.
The other thing is this, my pet, as you know, my pet thing is about supplementation. And this study out from Bristol University team analyzed 20,000 British men aged between 50 and 69, and they found that with 10 portions of tomatoes each week, the prostate thing is reduced by 24%. It also at the same time analyzed selenium and calcium in the same study and found that all these things are the triumvirate, if you like. All these things are together would be very, very beneficial. What's your thinking on this supplementation? And I might add that I myself, as you know, am taking lycopene, which I'm ordering from England, which has got which is really the key in the thing in the tomato. Yeah,
that's the effect of cooking your tomatoes. You get the lycopenes. Yes, it's one of those things where there's often circumstantial evidence becomes fact, somehow morphs into fact, and the other thing is that we also have a situation where sometimes, I guess, statistically significant differences might do not translate into actual clinical difference. I'll give you an example of where you could say, let's say that you've got a particular compound reduces prostate cancer, and you say it reduces it by 20%, and you think, wow, that's great. But if you actually look at, you've got to look at the raw figures, and it might be a case of where you've got, say, it's gone down from 0.1 to 0.02. And it seems like a big drop. You see that happen a lot. It's not really a great example, but that's the point I'm trying to make, is that there's statistics, and there are damn statistics. Now, the other thing is that we also have to look at where clinical trials have actually been done. Sometimes it takes a major clinical trial to disprove something. And one of the best clinical trials was actually the SELECT study. And the SELECT study was a huge, expensive, government-funded study which looked at selenium and vitamin E as a chemopreventative agent for prostate cancer. Now, it's a hugely expensive study. As you think about it, you've got hundreds of thousands of men involved in these sorts of studies. They actually cut the study short because it became very clear that halfway through the study that there was no difference at all, and that was going to continue to be the trend, and they considered it to be unethical to continue to have men on this study, which was actually leading to nowhere. So they cut short that study and were able to conclude that vitamin E and selenium made no difference. Now the trouble is we haven't actually done the studies to look at the impact of, say, vitamin D and other lycopenes with that sort of rigour. We haven't tested pomegranate to that sort of rigour. So until that happens, there's all this circumstantial evidence, and what we can say is that, well, it does no real harm. I don't object to men going on it. It does no harm. But it's a big deal to set up a clinical trial to prove something like that, whereas I think the money is better directed into therapies that are urgently needed to deal with what's still a very high mortality rate from a cancer.
Henry, recently in the press there was a report of research at University of Queensland into cane toad venom and its efficiency to attack prostate cancer cells.
Yes.
Would you like to comment?
Yeah, it's very interesting. That's right. It was a Chinese researcher who had discovered a similar type of venom in some Chinese toad, and they worked out that the cane toad had something which was not hugely dissimilar. Look, it's a long way off. At the moment, it's speculative, and there is no hard data that really. It made the news because it's one of those grabbing stories that'll suck you in and read it, but there's actually no data. It's just simply a speculative comment. The other thing we've also got to be very careful about a lot of these things that seem to work in a test tube. So in a test tube, if you've got a substance that kills prostate cancer, it doesn't necessarily mean it's going to be good clinically. For example, I would suggest that it's my belief that if I was to take a suspension of prostate cancer cells and to pour kerosene in it, that would probably kill it, kill them. But the thing is that we know that if we start injecting kerosene into our veins, we're not going to do too well. So that's why, at the same time, I don't mean to be totally dismissive about that, but we need much greater proof before we can actually, get too excited.
Henry?
Hi. I was just wondering, well, first of all, it's amazing how they actually, what are they doing to be mucking around with cane toads to find these sorts of things out in the first place?
It's one of those things where you've got all these cane toads, you're just trying to find a use for them.
That's right. That's right. My question was, is there any difference between zolidonic acid and alendronic acid?
Yes.
And if so, what is it, please?
Yeah, there are some subtle differences. They both, they're both in the bisphosphonate class. The main difference is that the former is off patent, so it's cheap, and the company doesn't want to market it. But with the latter, with the zoledronic acid in particular, one feature which does set it aside from the other bisphosphonates is the fact that it can lead to increase in your bone mineral density. When you actually have, with the other bisphosphonate drugs, what they do is they actually stop further deterioration of bone loss. So really when you go onto drugs like phosphonate, they're not actually making your bones stronger. They're actually stopping the rot, and so they try to prevent you from losing more than you've already lost. Whereas zoledronic acid and denosumab both are capable of increasing your bone mineral density, which is a definite advantage over the others.
Oh, thank you, Henry. I've got a question here.
Sure.
After robotic surgery and radiotherapy, the PSA starts to rise, and you're confronted with a choice between ADT and orchidectomy. What's your comments on that?
Well, my first comment is on the basis of my talk today. In the carefully selected man, I want to try to prevent that man going on to ADT if we can. And what we'd be doing now is we'd be getting them to have, right now, this week, we'd be getting them to have a PET choline scan, and maybe next week it would be a PSMA scan. Okay, but anyway, on your question, let's assume that they've reached the stage where they need to have some form of androgen deprivation therapy, and as you know, the injections and an orchidectomy are actually equivalent in their ability to as a first line form of hormone treatment. But why do I give injections and not the surgery? Well, on one side, I know that surgery is actually good for this country. It actually saves money. But when you actually look at the formulary, if I want to add a drug called Cosudix, which is an anti-androgen drug later as a second-line hormone treatment, it's not covered by the PBS. So it's all practical reasons why I'm not prescribing or doing orchidectomies. Once you've done an orchidectomy, because the rules and the prescribing rules make it very clear that Cosudix can only be prescribed in conjunction with an injection, hormone injection. It doesn't allow you to give, you don't get the subsidised drug if you've done an orchidectomy. It doesn't mean it's right. In fact, I think it's wrong. I think that we should be able to give Cosudix if somebody's had an orchidectomy in the past. But from a practical perspective and being pragmatic, I want to have that option available to me to give Cosudix. So that's why I give the injections.
Okay, thank you.
If I was a bean counter, then certainly orchidectomy is just as effective. But then there's also the psychological issues. A lot of men are not too, find it difficult to come to terms with having an operation that does remove their testicles.
The robotic surgery, some medical funds don't cover it because it's regarded as experimental. How does this come about in the Australian private health system?
Well, it's not actually so much experimental. The reason they don't cover it is, there is a component. As you know, look, all technology companies make their money from creating some aspect of the technology that you've got to throw away. They've got to make, if you have something disposable, then it creates these recurring costs, the cash cow for the company. Back in the old days, they used to make a metallic retractor or something. You'd buy it, the hospital would buy it, and they wouldn't have to buy another one for years unless you lost it. So, anyway, what happens is it creates a thing called the consumables charge, and health funds are not under obligation to cover the cost of the consumable. It's an optional thing. So, therefore, some health funds will cover it and others won't. Now, the consumables charge, generally the going price across Sydney is about $4,050, I think it is, roughly that. And some health funds do cover it and some don't. For example, HCF covers the entire amount. So therefore, if you're an HCF and you're trying to decide between robotic and open, I think it's a no-brainer. On the other hand, if you've got NIB and Medibank Private, they don't cover any of it. And often the way they, they've made a commercial decision and they'll come up with whatever explanation they want to. And I don't agree that it's not experimental. I think that there's been, an enormous amount of data that's been published and peer-reviewed data that's been published on robotic surgery. It's bona fide treatment. It's here to stay.
I've got one about infection from procedures such as biopsy and surgery. So given that these things are on the rise, I'm not really clear how big a problem it is with the various procedures like biopsy and prostatectomy and even rebores and so forth.
Now, you raise an excellent question. The question is the real issue of so-called sepsis. I think it's Sepsis Week, isn't it, at the moment? Yeah. About sepsis is really is primarily to do with the prostate biopsy process. The risk of infection after surgery is incredibly low nowadays. You've got to you really got to draw a short straw of life, as I say, to get an infection early after the surgery. That's because we get the whip out and you're up about early, get you home quickly and away from hospital bugs and get washed over with your domestic bugs when you get home. That's what basically happens. When somebody has a prostate biopsy, we're actually doing it through the rectum when you do the transrectal approach. And some people call it a transfecal sort of biopsy. And naturally with that comes a risk of infection. And one of the reasons why the infections are on the rise is because we're a much more mobile population and we're starting to, a lot of people are starting to bring back these nasty bugs into Australia. These nasty bugs, an example of one is called extended spectrum beta-lactamase E. coli, which is or ESBL, which is a supercharged bug that can fight off just about anything. And the reason why these bacteria are on the rise is because, particularly in China and India, there's indiscriminate use of antibiotics in agriculture. So a lot of the agriculture, imagine that, they shove antibiotics into the fertiliser, they shove antibiotics into all the feed, and what that does is it breeds out superbugs. So there was an interesting study done in the streets of Delhi where they swabbed puddles, and they found that almost a 100% positive culture of ESBL bacteria. And so when you've got Australians, we travel quite a lot. You go travel overseas, you ingest the food there, and you come back and you colonise with the stuff. So it means that we have to get a bit smarter about how we do biopsy. All right, so how do we get smarter? The first step is let's get smarter about who we biopsy. We've got to stop doing indiscriminately biopsying and everybody's just because they've got an elevated PSA. If the PSA goes up on one occasion, does it really matter if we don't make the diagnosis now and make the diagnosis 6 months later after a period of watching? makes no difference at all. You've got some time up your sleeve. So, because sometimes you get the people have these up and downs and goes back down and never goes up again. And you've saved them a biopsy. We use MRI scanning to help triage who should have a biopsy or not. The other thing we also do is we also take a history. For example, if I know that you travel to, say, to Shanghai every month, then I'm probably going to hit you harder with your antibiotic prophylaxis, because I target you as somebody who's, a higher risk person. The other way out is to do what's called transperineal biopsies, because if you do it through the patch of skin between the back of the scrotum and the anus, if you stick a needle through there, the risk of infection is basically zero.
Is the procedure as effective at finding cancer, though?
Yes, yeah, they're both effective at finding cancer. Now, the thing about going in for the perineum, while some people are getting out there and saying, yes, we've got to do it all that way, there's always devil in the detail. Through the perineum is an incredibly painful experience to the extent that no man can tolerate under local. You've got to get under a general anaesthetic. So that takes up a lot of resources. So imagine if we suddenly shifted overnight, we shifted 20 to 30,000 biopsies done in this country each year and suddenly shoved up into the operating rooms. Just imagine the impact that would have. And the other bit of devil in the detail is that what about the, up to 5 to 8% of men in some series, they go into acute urinary retention. They can't pee afterwards and have to have a catheter put in. So there's pros and cons of every approach. The strategy that we've just started using is a strategy called betadine suppositories. We just started that. And it's still early days, but so far we haven't had a single case of sepsis since we've started using it. Some people poo-pooed the idea, no pun intended, the idea of using antiseptics in the rectum. But and they almost threw the baby out with the bathwater on that, because people tried, washing out the rectum with betadine, and they found that it didn't make any difference. But you think about what happens when you squirt an antiseptic down somebody lying on the left-hand side and up their bum. It's going to go whoosh straight up the colon, down the left side, but down the sigmoid colon, which is your, the main colon. It's just going to go away, right down start right up the colon, I should say, not down. And well away from where you want it to work. So what you really want to do, you want to be able to marinate the lining of the rectum just in front of the prostate. And if you think about it, you put a betadine suppository in there, it sits there and it just melts. And I like the word marinates the rectum. It's not quite teriyaki sauce, but it looks like it. But that makes a lot of sense, because there actually has been a number of clinical trial, very good clinical trial was actually done by Koreans. And this is sometimes a problem with the Western press, is we sometimes ignore really good studies done in Asia. And they did a randomised controlled trial saying a substantial reduction in sepsis rates by using this betadine suppository. So one of the reasons we ignored it, because where do you get a betadine suppository from? Nobody makes the darn things. But some clever compounding pharmacist in Western Australia thought, here's a marketing opportunity. And he actually started manufacturing them. And you've got urologists now who are ordering them from all over the place. He's got himself a nice little market. And good on him.
But I'd like to thank Henry for the presentation. Again, an excellent presentation. As you say, you're amongst friends. It's easily understood. And it covered a topic, and as you say, it gives us all hope. And I think this is one of the main things that we get out of presentations from all the people that present here, is that there's hope. Even if we're having a bit of a rough patch with our prostate cancer, there's something on the way that's going to help us. And I think it's just terrific to hear about all these new ideas, technologies, etc., because hope is terrific for all us people. But thank you again, Henry. We always enjoy your presentation. Would you please give Henry a clap? Excellent.